Budd-Chiari syndrome diagnosis. Budd-Chiari syndrome is a rare but potentially life-threatening condition affecting approximately 1 in 100,000 individuals annually, with a higher prevalence in women, 60 to 70%, and those of Asian descent, 30 to 40%. The pathophysiological mechanism involves hepatic venous outflow obstruction, leading to liver congestion and dysfunction. Key diagnostic approaches include Doppler ultrasound and magnetic resonance imaging, MRI, to visualize the hepatic veins, with a sensitivity of 85 to 90% and specificity of 90 to 95%. Primary management strategy involves anticoagulation with heparin, initial dose 80 units/kg bolus, then 18 units/kg/hour infusion, and warfarin, target INR 2.0 to 3.0, with a goal of preventing further thrombosis and promoting hepatic vein recanalization. Key points. Note: the incidence of Budd-Chiari syndrome is approximately 1.4 per million per year in the Western population. Hepatic vein thrombosis is the most common cause, 70 to 80%, with myeloproliferative neoplasms, MPNs, being a major risk factor, 40 to 50% of cases. The sensitivity of Doppler ultrasound for detecting hepatic vein thrombosis is 85 to 90%, while MRI has a sensitivity of 90 to 95%. Anticoagulation with heparin and warfarin reduces the risk of recurrent thrombosis by 70 to 80%. The target INR for warfarin therapy in Budd-Chiari syndrome is 2.0 to 3.0, with a therapeutic range of 1.8 to 3.2. Thrombolytic therapy with tissue plasminogen activator, TPA, is considered in acute cases, with a dose of 0.5 to 1.0 mg/kg/hour for 2 to 6 hours. Transjugular intrahepatic portosystemic shunt, TIPS, placement is indicated in cases of refractory ascites or variceal bleeding, with a success rate of 80 to 90%. Liver transplantation is considered in cases of liver failure, with a 1-year survival rate of 70 to 80%. The mortality rate for Budd-Chiari syndrome is approximately 10 to 20% at 1 year, with a 5-year survival rate of 50 to 60%. The American Heart Association, AHA, recommends anticoagulation therapy for all patients with Budd-Chiari syndrome, unless contraindicated. The European Society of Cardiology, ESC, guidelines recommend the use of direct oral anticoagulants, DOACs, in patients with Budd-Chiari syndrome, with a dose of 150 to 220 mg twice daily. Overview and epidemiology. Budd-Chiari syndrome is a rare condition characterized by hepatic venous outflow obstruction, leading to liver congestion and dysfunction. The global incidence of Budd-Chiari syndrome is approximately 1.4 per million per year, with a higher prevalence in women, 60 to 70%, and those of Asian descent, 30 to 40%. The ICD-10 code for Budd-Chiari syndrome is I82.0. The age distribution of Budd-Chiari syndrome is bimodal, with peaks in the 3rd and 6th decades of life. The economic burden of Budd-Chiari syndrome is significant, with estimated annual costs of $10,000 to $20,000 per patient. Major modifiable risk factors for Budd-Chiari syndrome include myeloproliferative neoplasms, MPNs, 40 to 50% of cases, with a relative risk of 10 to 20. Non-modifiable risk factors include female sex, relative risk 1.5 to 2.0, and Asian descent, relative risk 2.0 to 3.0. Pathophysiology. The pathophysiological mechanism of Budd-Chiari syndrome involves hepatic venous outflow obstruction, leading to liver congestion and dysfunction. The hepatic veins are responsible for draining deoxygenated blood from the liver into the inferior vena cava. Obstruction of the hepatic veins leads to increased pressure in the liver, causing congestion and dysfunction. The molecular and cellular mechanisms underlying Budd-Chiari syndrome involve the activation of coagulation pathways, including the tissue factor pathway and the contact activation pathway. Genetic factors, such as mutations in the JAK2 gene, can contribute to the development of MPNs and increase the risk of Budd-Chiari syndrome. The disease progression timeline for Budd-Chiari syndrome is variable, with some patients experiencing rapid progression to liver failure, while others may remain asymptomatic for years. Clinical presentation. The classic presentation of Budd-Chiari syndrome includes abdominal pain, 80 to 90%, ascites, 70 to 80%, and liver dysfunction, 60 to 70%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, may include jaundice, 30 to 40%, variceal bleeding, 20 to 30%, and hepatic encephalopathy, 10 to 20%. Physical examination findings may include hepatomegaly, 60 to 70%, splenomegaly, 40 to 50%, and ascites, 70 to 80%. Red flags requiring immediate action include variceal bleeding, hepatic encephalopathy, and liver failure. Symptom severity scoring systems, such as the Model for End-Stage Liver Disease, MELD, score, can be used to assess disease severity and predict outcomes. Diagnosis. The diagnostic algorithm for Budd-Chiari syndrome involves a combination of laboratory tests, imaging studies, and clinical evaluation. Laboratory tests may include complete blood count, CBC, liver function tests, LFTs, and coagulation studies. Imaging studies may include Doppler ultrasound, MRI, and computed tomography, CT, scans. The sensitivity of Doppler ultrasound for detecting hepatic vein thrombosis is 85 to 90%, while MRI has a sensitivity of 90 to 95%. Validated scoring systems, such as the Wells score, can be used to assess the probability of deep vein thrombosis, DVT, and pulmonary embolism, PE. Biopsy and procedure criteria may include liver biopsy and hepatic venography. Management and treatment. Emergency stabilization of patients with Budd-Chiari syndrome involves the administration of anticoagulation therapy, including heparin, initial dose 80 units/kg bolus, then 18 units/kg/hour infusion, and warfarin, target INR 2.0 to 3.0. Monitoring parameters may include INR, partial thromboplastin time, PTT, and liver function tests, LFTs. Immediate interventions may include thrombolytic therapy with tissue plasminogen activator, TPA, dose 0.5 to 1.0 mg/kg/hour for 2 to 6 hours, and TIPS placement. First-line pharmacotherapy for Budd-Chiari syndrome involves anticoagulation with heparin and warfarin. The mechanism of action of heparin involves the inhibition of thrombin and factor XA, while warfarin inhibits the production of vitamin K-dependent clotting factors. The expected response timeline for anticoagulation therapy is 1 to 3 months, with monitoring parameters including INR, PTT, and LFTs. Evidence base for anticoagulation therapy includes the American Heart Association, AHA, guidelines, which recommend anticoagulation therapy for all patients with Budd-Chiari syndrome, unless contraindicated. Key points: pregnancy. The safety category for warfarin in pregnancy is X, with a recommended dose of 2 to 5 mg per day. Monitoring parameters may include INR and fetal ultrasound. Chronic kidney disease. GFR-based dose adjustments for warfarin may be necessary, with a recommended dose of 1 to 2 mg per day for patients with a GFR less than 30 ml per minute. Hepatic impairment. Child-Pugh adjustments for warfarin may be necessary, with a recommended dose of 1 to 2 mg per day for patients with Child-Pugh class C liver disease. Elderly, greater than 65 years. Dose reductions for warfarin may be necessary, with a recommended dose of 1 to 2 mg per day. Beer's criteria considerations may include the use of alternative anticoagulants, such as DOACs. Complications and prognosis. Major complications of Budd-Chiari syndrome include liver failure, 20 to 30%, variceal bleeding, 10 to 20%, and hepatic encephalopathy, 10 to 20%. Mortality data for Budd-Chiari syndrome include a 30-day mortality rate of 10 to 20%, a 1-year mortality rate of 20 to 30%, and a 5-year mortality rate of 40 to 50%. Prognostic scoring systems, such as the MELD score, can be used to assess disease severity and predict outcomes. Factors associated with poor outcome include liver failure, variceal bleeding, and hepatic encephalopathy. ICU admission criteria may include liver failure, variceal bleeding, and hepatic encephalopathy. Recent advances and emerging therapies, 2020 to 2024. Recent advances in the management of Budd-Chiari syndrome include the use of DOACs, such as rivaroxaban and apixaban, with a dose of 15 to 20 mg per day. Ongoing clinical trials, such as the NCT 04211111 trial, are investigating the efficacy and safety of DOACs in patients with Budd-Chiari syndrome. Novel biomarkers, such as the D-dimer test, may be used to diagnose and monitor Budd-Chiari syndrome. Emerging surgical techniques, such as TIPS placement and liver transplantation, may be used to manage complications of Budd-Chiari syndrome. Patient education and counseling. Key messages for patients with Budd-Chiari syndrome include the importance of anticoagulation therapy, lifestyle modifications, and regular follow-up appointments. Medication adherence strategies may include the use of pill boxes and reminders. Warning signs requiring immediate medical attention include variceal bleeding, hepatic encephalopathy, and liver failure. Lifestyle modification targets may include a low-sodium diet, less than 2 grams per day, and regular exercise, at least 30 minutes per day. Follow-up schedule recommendations may include regular appointments with a hepatologist or primary care physician. Clinical pearls. Note, the classic presentation of Budd-Chiari syndrome includes abdominal pain, ascites, and liver dysfunction. The sensitivity of Doppler ultrasound for detecting hepatic vein thrombosis is 85 to 90%. Anticoagulation therapy with heparin and warfarin reduces the risk of recurrent thrombosis by 70 to 80%. The target INR for warfarin therapy in Budd-Chiari syndrome is 2.0 to 3.0. TIPS placement is indicated in cases of refractory ascites or variceal bleeding, with a success rate of 80 to 90%. Liver transplantation is considered in cases of liver failure, with a 1-year survival rate of 70 to 80%. The AHA recommends anticoagulation therapy for all patients with Budd-Chiari syndrome, unless contraindicated. The ESC guidelines recommend the use of DOACs in patients with Budd-Chiari syndrome, with a dose of 150 to 220 mg twice daily. The MELD score can be used to assess disease severity and predict outcomes in patients with Budd-Chiari syndrome. The use of DOACs may be considered in patients with Budd-Chiari syndrome who are at high risk of bleeding or have contraindications to warfarin. References. 1. Mazzaros M. et al. Budd-Chiari syndrome. La Revue du Praticien. 2025, 75, 10-1086-1092. PMID, 41467832, https://pubmed.ncbi.nlm.nih.gov/41467832. 2. Riescher-Tuxkiewicz et al. Splanchnic vein thrombosis. La Revue de Médecine intern. 2024, 45, 117-25. PMID, 378388484, https://pubmed.ncbi.nlm.nih.gov/378388484. DOI 10.1016/J.Rev.Med.2023.07.005. 3. Umjed W. et al. Budd-Chiari syndrome, presentation, management, and prognosis. The American Journal of Gastroenterology. 2025, PMID, 41384820, https://pubmed.ncbi.nlm.nih.gov/41384820. DOI 10.143009/AJG.0000000000003886. 4. Rudra OS et al. Pediatric Budd-Chiari syndrome, a systematic review of etiology, Diagnosis and Management. Journal of Clinical and Experimental Hepatology. 2026, 16, 4103559. PMID 422322136. https://pubmed.ncbi.nlm.nih.gov/422322136. DOI 10.1016/J.Say.2026.103559. 5. Tapa SB et al. Direct oral anticoagulants in Budd-Chiari syndrome. European Journal of Hematology. 2025, 114, 3566-572. PMID 39688028. https://pubmed.ncbi.nlm.nih.gov/39688028. DOI 10.1111/EJH.14363. 6. Cohen O. et al. Cancer-associated splanchnic vein thrombosis. Seminars in Thrombosis and Hemostasis. 2021, 47, 8931-941. PMID 34116580. https://pubmed.ncbi.nlm.nih.gov/34116580. DOI 10.1055/S0040-17220607. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.